It's a great evening. I think we can start the session right now. So at the outset, I would like to welcome Dr. Joe sir, the President IAP Kerala. Sir, we have great pleasure for you having here, sir, actually. And this is the 10th session also, so it is a great auspicious moment for us, actually. And here Dr. Johnny Sebastian sir also was very enthusiastically encouraging us from the beginning, and sir was himself attended many our journal clubs and has contributed and all. Sir, welcome to Johnny Sebastian sir also, sir. And also welcome to Dr. Rugmini madam, our IAP Trivandrum president. Good evening, madam, and welcome to the session. And we have none other than Dr. Ramankutty sir also right here with us for leading us and teaching us, guiding and all. Ramankutty sir, a very good evening to you, sir. And we have Dr. Soumya Kurup madam. Madam is a consultant endocrinologist at Cosmopolitan Hospital, Trivandrum. And a good evening to Soumya madam.
Yes, sir.
And we have our young energetic aspirant JRs from Cosmo Hospital, none other than Dr. Jeswin and Dr. Anju. Good evening, Dr. Jeswin and Anju, madam. Anju, doctor. And I extend my warm welcome to all. And I think Dr. Krishnamohan sir also has joined actually. Good evening, Dr. Krishnamohan sir, IAP Secretary Trivandrum. Sorry, Kerala.
Good evening, Anju. Good evening. Good evening.
Great evening, sir. Actually, very happy to have you here. Actually, and I think it is. And Dr. Shija Madhavan, Kim's endocrinologist, madam, has also joined. Good evening, Dr. Shija madam. And I think it is already 7:30 only, so most of the people and the members of IAP teachers will soon join and all. I think we will directly go to the session and all. Before that, I would like to request Dr. Rugmini madam, IAP President Trivandrum, to tell her thoughts, share her thoughts and comments. Over to Dr. Rugmini madam.
Respected State President Joe sir, Secretary Dr. Krishnamohan, and the backbone of our journal club, Ramankutty sir, our past State Secretary Dr. Johnny Sebastian, Dr. Soumya, today's mentor, and today's presenters, the JRs from Cosmopolitan, Dr. Jeswin and Dr. Anu, and all other IAPians who are attending today's session. Good evening. Now coming to the program of Journal Club, today is a special day for us. The Journal Club, which was a project which was in my mind for so many years, and when I became the IAP president last year, with the special support of Dr. Vijay Kumar, then IAP president, state president, and Dr. Johnny Sebastian, we inaugurated the session 10 months back. So this is our 10th journal club, and I would like to specially congratulate I can't say three backbones because we don't have three backbones. We'll say three pillars of the journal club. Ramankutty sir, Padmanabhan sir, and Anju K Kanmani. And the process starts the moment one journal club finishes, I will start getting messages from Anju K Kanmani. What next, madam? What next, madam? So I usually what I do is 2-3 days I'll keep quiet and then only I reply for him. He is that enthusiastic, and that is why this journal club goes on like this. And you all know that this is a 10th journal club, and this journal club is unique for IAP Trivandrum. I repeat, it is unique for IAP Trivandrum, and from my knowledge, no other branch from all over the nation, no other branch is conducting such a program, that too this much regularly. So this is a credit for us, and it's a pleasure for IAP Trivandrum. And thank you all for giving us the opportunity to serve like this. And a special thanks to Ramankutty sir. Sir is attending all the 10 journal clubs. He was leading us, and by that only, the majority of us who were standing at the questions, what is a p-value and what is chi-square, just we graduated from that to the higher levels, and I think this will help us a lot to get a quality research papers from our side. So my request to everybody, ask your PGs, ask your residents to attend this journal club regularly. Thank you all. Now I invite, being the 10th journal club, I invite our dear President, Joe sir, to inaugurate the session and say a few words. Sir, please.
Thank you, Rugmini Madam. The President of IAP Thiruvananthapuram branch and Secretary Dr. Benno. The already Dr. Rugmini Madam mentioned the pillars of Thiruvananthapuram Journal Club, Dr. Ramankutty sir, Dr. Padmanabhan sir, and Dr. Anju K Kanmani. They are regularly conducting this pediatric journal club Thiruvananthapuram branch, and with the support from our dynamic IAP Thiruvananthapuram branch secretary Dr. Benno, Dr. Rugmini, and with all support and the leadership of Dr. Rugmini Madam is conducting a webinar series of journal club for the last 10 months. I think it is a landmark of Thiruvananthapuram branch is concerned. I take the opportunity as a president of IAP Kerala. I take the opportunity to congratulate IAP Thiruvananthapuram branch president Dr. Rugmini, Dr. Benno, Dr. Anju K Kanmani, Dr. Padmanabhan sir, and Dr. Ramankutty sir for this wonderful program conducted but beneficial for postgrad students and the practicing pediatricians regarding the new knowledge in the journal club regarding how to give the new input of their knowledge regarding the practices concerned. And I take the opportunity to congratulate the Thiruvananthapuram branch is doing a wonderful job, both academic and social activities. Whenever there is a program of Thiruvananthapuram branch, I think that will be useful for all of the practicing pediatricians and postgrad students. That's the motto of Thiruvananthapuram branch. There are good academics programs they are conducting. They are regularly conducting Tuesday series for the last 2 years. And this is the 10th journal clubs program regularly conducted by one of the Thiruvananthapuram branch. I think as Dr. Rugmini Madam mentioned, the Thiruvananthapuram branch is the only branch conducting the journal club regularly and every month for the last 10 months. I think big congratulations to all of the backbone for this journal club programs. As Ramankutty sir is mentioned, Ramankutty sir is a man with a dynamic input in the regarding the journal club assessments. I think Ramankutty sir is equivalent to William Osler, who started the journal club in 1875. That time, his motto was to disseminate the knowledge on the recent medical knowledge in the field of practicing pediatricians. That was his knowledge. This motto, William Osler started his journal club in 1875. I think Ramankutty sir is also doing a wonderful job. I witnessed his journal club discussion. Last 5 journal club already participated. I got a lot of information from Ramankutty sir. I think that Ramankutty sir is a big academic for the IAP Thiruvananthapuram branch conducting the journal clubs. I think this will be. I think that today the Dr. Soumya is here, the consultant pediatric endocrinologist from Cosmopolitan Hospital. And today the presentators are Jeswin Mary James from Cosmopolitan and Anju Paul also from the Cosmopolitan Hospital, I think so. So they are doing I think that to preparing a presentation journal club is a very difficult task. You have to go through journal very meticulously and by word by one, then only they can able to present the topic. I think they have done a wonderful job with the mentor of Dr. Soumya. They have done a wonderful job for that. Today, I think this program will be regarding the endocrinology issue, the serum inhibin for differentiating between congenital hypogonadotropic and hypogonadism and constitutive delay of growth and puberty, a systematic review and a meta-analysis. I think that will give a lot of input regarding the endocrinology aspect of the hypogonadism and hypogonadotropic disorders, congenital hypogonadism disorders. In regarding that, I think this program will be very useful for all of us. And with this word, I officially declare that this journal club, 10th journal club of IAP Thiruvananthapuram branch is officially inaugurated. Jai Hind, Jai IAP. Congratulations to IAP Thiruvananthapuram.
Thank you so much, madam.
Thank you, Joseph. Now I invite Dr. Krishna Mohan, our secretary, for the felicitation, propose a felicitation. Dr. Krishna Mohan, please.
Okay, thank you, madam. Respected State President, President IAP Thiruvananthapuram, Rugmini Madam, Benno, Ramankutty sir, Padmanabhan sir, and my dearest friend, Dr. Anju K Kanmani, and today's faculties. So I take this opportunity to congratulate IAP Thiruvananthapuram for their excellent initiative. As Rugmini Madam mentioned, I think it is the first of its kind from Kerala on any of the Kerala IAP branches. So best wishes for the program. And beyond that, IAP Thiruvananthapuram is doing wonderful job. Special mention about Dr. Benno, the secretary, the most vibrant secretary. So best wishes for the program. Thank you.
Thank you, Dr. Krishna Mohan. When we move ahead, and when we move ahead very fast, we cannot forget the past. So Dr. Johnny Sebastian was the past secretary, IAP Kerala, and I gave a special invitation to Dr. Johnny Sebastian today to attend this meeting. And I request Johnny Sebastian to say a few words.
Chief guest of the day, our respected State President, Joseph, Dynamic Secretary of IAP Kerala, Krishna Mohan, and the dynamic people, the trio carrying out this journal club throughout these 10 months. Padmanabhan sir, Ramankutty sir, and the energetic Anju K Kanmani, seniors and dear colleagues. At the outset, let me congratulate IAP Thiruvananthapuram under the able guidance of Rugmini Madam and Dr. Sibi, who took up this initiative and entrusted this journal club meetings to Ramankutty sir and Padmanabhan sir and Anju K Kanmani, who have been doing this very meticulously throughout these 10 months. And it has been of lot of encouragement for the PG students as well as the practicing pediatricians. So I'm so happy that I had been a part of this team at the initial stage, and I wish this endeavor all success. Thank you. Jai Hind, Jai IAP. Thank you.
And thank you, sir. Now I invite Dr. Ramankutty sir to say a few words, and then we will move on to the journal club of the day. Sir, please.
Thank you. Good evening. I don't want to talk too much because I think it's already late. I'm very happy that I could be part of this endeavor because I remember my roots. I was trained as a pediatrician. Although like a prodigal son, I moved away. But when I came back, as the biblical story goes, I was treated with a fatted calf. So I'm so very happy because you have given me this opportunity. And of course, my good friend Dr. Padmanabhan was the reason behind my being part of this. So I'm thankful to him also. So anytime IAP wants my help or expertise, I'm always willing to be part of this. So I'm very happy of, and I am very good. It's very good that you are completing 10 sessions. To be very frank, when we started, I thought it would not last very long, but somehow it is. I think it's due to mainly because of Dr. Anju and his enthusiasm that it lasted so long. But I think it's a very wonderful job, and congratulations to everybody who's involved. Thank you.
Thank you very much, sir. Now I hand over to Dr. Anju Kanmani to carry on with the session.
Yeah, thank you so much, madam. And respected teachers, seniors, and colleagues, we will directly go to the session. And I would like to request Dr. Soumya madam to throw some light, set the background, and put us in the groove for the journal club today. Over to Soumya madam.
Thank you, sir. Am I audible?
Yes, ma'am.
Good evening to all the respected faculties here. First of all, I would like to pay my respects to all my senior teachers over here. And I also thank IAP for giving me this opportunity, and I also congratulate IAP Thiruvananthapuram for this venture. So this journal club is on the topic Serum inhibin V for differentiating congenital hypogonadotropic hypogonadism and constitutional delay of growth and puberty. It's a systematic review and meta-analysis. This journal club will be divided into 2 sessions, 2 parts. The first PG, Dr. Jeswin, will be presenting the journal proper, followed by Dr. Anju Paul, who will be presenting the statistical analysis as well as the critical appraisal of the systematic review with respect to the PRISMA guidelines. So to begin with, I shall I'll just have a brief presentation just to throw some light on what the topic is being dealt in this journal. So just to make you all familiarized with some of the terms used in this journal. So this journal is about differentiating two causes of delayed puberty. So what is delayed puberty? As we all know, puberty, just like any other variable in the community, it has a Gaussian distribution. So anything which is lying beyond 2 standard deviations is abnormal. So delayed puberty is the puberty occurring at an age or absence of puberty even after 2 standard deviations from the mean of age for that population. And the first sign of puberty in boys is an enlargement of testicular volume. And the first sign of puberty in girls is the breast development. So absence of testicular enlargement beyond 4 ml by 14 years of age and absence of breast development even after 13 years of age in girls is considered as delayed puberty. So just moving to the causes of delayed puberty, just one point about the physiology of puberty. The glands involved or the glands orchestrating this puberty are mainly the hypothalamus, the anterior pituitary, and the gonads. It all starts from the hypothalamus, where it secretes gonadotropin releasing hormone. And this gonadotropin releasing hormone stimulates the anterior pituitary, and the anterior pituitary secretes gonadotropins, namely the LH and FSH, luteinizing hormone and the follicle stimulating hormone. This gonadotropins come down and they stimulate the gonads. And the gonads secrete the respective gonadal steroids. Testis secretes testosterone and estrogen and progesterone from the ovary. Now, this gonadal steroids, they will have a feedback inhibition on both anterior pituitary as well as the hypothalamus, so that the gonadotropins does not get elevated. They are kept at a check. That is called the feedback inhibition of this gonadal steroids. So, what are the causes of delayed puberty? It can broadly be classified in 2. So before that, we should understand one thing, that this axis, this hypothalamic pituitary gonadal axis, this whole axis is active during the fetal life. And immediately after birth it is very active. This time period is called the mini puberty, where there will be gonadotropins will be elevated to the level of puberty. So after this mini puberty, that is after the infancy period, after 1 year of age, this axis goes in for a suppression. There are various factors which keeps this axis under suppression. And as the childhood progresses and the child reaches an age for puberty, an optimal age for puberty, this suppression is uplifted and the hypothalamus wakes up and secretes gonadotropin releasing hormone. And so the pituitary responds to this gonadotropin releasing hormone by secreting the gonadotropins, namely LH and FSH, and thus the pituitary kickstarts. So the causes of delayed puberty. First is any problem with the hypothalamic pituitary system, the upper story, the central axis. Any problem with the hypothalamus or pituitary, that leads to decreased gonadotropin releasing hormone secretion from the hypothalamus, and there is decreased LH and FSH from the anterior pituitary. And so the gonadal steroids will also be low. So all the hormones are low. This is called hypogonadotropic hypogonadism. And the second group of disorders is any problem affecting the gonads itself, any problem with the testis or ovary. So there will not be any gonadal steroids. So there will be no gonadal steroids to cause a feedback suppression at the anterior pituitary and the hypothalamus. So that leads to an unchecked elevation of the gonadotropins. So the LH and FSH will be elevated, whereas the gonadal steroids will be lower. So this is called hypergonadotropic hypogonadism. So hypogonadotropic hypogonadism is anything affecting the hypothalamus and pituitary, and hypergonadotropic hypogonadism is anything affecting the gonadal axis. So moving to the causes of delayed puberty, as we all know, hypergonadotropic hypogonadism, the problems affecting the testis and ovary, there are inherited causes, there are genetic causes like Klinefelter syndrome, Turner syndrome, all other acquired causes also. And the cause of hypogonadotropic hypogonadism, or the diseases affecting the hypothalamus or pituitary, the important causes include any CNS tumors like craniopharyngioma, germinoma, any acquired causes like hypothalamic radiation, infiltrated disorders, or some congenital causes like multiple pituitary hormone deficiency or isolated congenital hypogonadotropic hypogonadism. This multiple pituitary hormone deficiency as well as this isolated congenital hypogonadotropic hypogonadism are caused due to certain mutations in the proteins responsible for the production secretion as well as action of the GnRH from the hypothalamus. So the hypothalamic as well as pituitary hormone production and the action has some mutation. So that is, so there is no anatomical abnormality like a tumor, but there is a functional abnormality because of this mutation. That is called isolated congenital hypogonadotropic hypogonadism, or Kallman syndrome is one of the mutation among that. And there is another variety called constitutional delay in growth and puberty. It is actually a hypogonadotropic hypogonadism, but it is a normal variant of the puberty because there is no anatomical problem, no functional problem, no mutation. The pituitary and hypothalamus is perfectly normal, but it is lazy. Even after the optimal age for kickstarting the puberty, this system stays dormant or suppressed. So it's called a lazy pituitary syndrome. But there is eventually this will get activated by itself as the child approaches 18 years of age. So there is no problem, but there is a delay and delayed activation. This age of puberty is delayed a bit. That's called constitutional delay in growth and puberty. So the two conditions under question in our meta-analysis is this congenital hypogonadotropic hypogonadism due to certain mutations in the pituitary, and this normal variant, constitutional delay in growth and puberty. So when a child presents with delayed puberty or an adolescent presents with a delayed puberty, so it is always a confusing situation whether this is a normal variant or is a pathological condition. So many times this constitutional delay in puberty children are overly evaluated extensively for a normal cause, and many times this CHH children, that is congenital hypogonadotropic hypogonadism, they may be reassured that this is normal, you may get a puberty later. So how to differentiate between these two is a clinical dilemma. So these are the normal variants of puberty. At both ends of puberty, there are a normal variant. Normally early puberty, that is a idiopathic central precocious puberty occurring premature puberty occurring as a normal variant. It is common in girls. Whereas this constitutional delay in growth and puberty, that is a delayed puberty occurring as a normal variant, is common in boys only. So the take-home point is that whenever a girl presents with delayed puberty or a boy presents with a precocious puberty, there are chances that it's always likely to be a pathological cause. And so how to clinically differentiate these two conditions, that is the constitutional delay in growth and puberty from this congenital hypogonadotropic hypogonadism. Clinically, the congenital hypogonadotropic hypogonadism children, their gonadotropins are lower.
Excuse
so
me,
they
madam.
will not. Pardon,
Madam,
sir?
due to lack of time, I would like to humbly request to keep it as short as possible so that we can. Thank you so much, madam.
Okay, sir. Okay, so only one more slide, sir.
Yes, sir.
So there are certain red flag signs like micropenis, cryptorchidism, midline facial defects in congenital hypogonadotropic hypogonadism, and the testicular volume will also be lower in CHH because of the absence of mini puberty. Whereas in CDGP, testicular volume is normal, height will be delayed, and bone age will also be delayed. And pubarchy, the development of pubic hair will also be delayed in CDGP. These are the tests which we use to differentiate clinically. Routinely, we use to differentiate these two conditions. One is basal LH to diagnose delayed puberty. To diagnose a hypogonadotropic hypogonadism, that is LH less than 0.3. Then we use a stimulation test to differentiate between these two. GnRH is given, GnRH agonist is injected, and we check the LH. LH is stimulatable in CDGP, whereas it is not stimulatable in CHH. And another test we use is inhibin B levels. Inhibin B levels are normal in CDGP children, and it is low in congenital hypogonadotropic hypogonadism due to absence of sertoli cell development. And the gold standard for differentiating these two is development.
Soumya, madam, excuse me, madam. Madam,
Sir.
are you showing the slides, madam?
Yes.
Actually, it is not being shared, actually. I mean, can you please share and just at least, I mean, we would like to see the table and that, actually.
Sir, I was sharing, sir.
Yeah, I thought madam was, I mean, impromptu telling. Yeah, please kindly share.
Oh, sorry. I didn't know that my
No
slides
issues,
were...
no issues, madam. Actually, I mean, the ideas were crystal clear, but we would like to, yeah, now it is visible. Now, can you just brush fast so that...
Okay, so this is delayed puberty. This is the cause. This is the axis which I told. This is the causes hypogonadotropic hypogonadism as well as the hypergonadotropic hypogonadism.
Yes, ma'am.
So these are the causes. The two causes of hypogonadotropic hypogonadism under question in our study are congenital hypogonadotropic hypogonadism due to mutations and constitutional delay in growth and puberty.
Yes, ma'am.
These are the normal variants. Then how to differentiate clinically between CDGP and CHH. And once they've done that, these are the tests which we do clinically. A basal LH to diagnose hypogonadotropic hypogonadism. That will be less than 0.3 in both these conditions.
Madam,
Then
could you please
we
show
do-
the clinical features to differentiate, madam? Just one. Can you just one word about that, madam?
I'm so sorry that I didn't. The slides were not visible. Okay, sir.
No issues, ma'am.
So these are the points which to differentiate it clinically. There will be certain red flag signs like micropenis, cryptorchidism, midline facial defects in congenital hypogonadotropic hypogonadism, and the testicular volume will also be very low because of absent mini puberty in congenital hypogonadotropic hypogonadism. And in CDGP, the mini puberty was normal, so the testicular volume is usually more than 2 ml. And there will be delay in height too, height delay and a skeletal development delay also, that is a bone age delay also in CDGP. And the pubic hair development will also be delayed in CDGP. And there will be a family history in one of the parents, more likely in CDGP.
Okay, okay, madam.
So, and this is a test, basal LH I described to diagnose hypogonadotropic hypogonadism. Then we move on to differentiate between these two. We give GnRH agonist, that is the hypothalamic hormone. The agonist of that hormone we give, and we stimulate the pituitary with that. In CDGP, the pituitary is normal, so it is stimulatable. The LH will rise more than 5.3 at 1 to 4 hours.
Okay,
Whereas in congenital hypogonadotropic hypogonadism, there is a defect in the pituitary. So this, even with GnRH agonist stimulation, it will not be stimulatable. And inhibin B is another test. Inhibin B will be normal in CDGP, whereas it will be low in congenital hypogonadotropic hypogonadism due to the lower Sertoli cell mass in CHH because of a low testicular volume. And the gold standard test to differentiate these two conditions is a follow-up when the child starts developing puberty by the age of 18 years at least. This is the gold standard for diagnosing CDGP because there are various partial forms of congenital hypogonadotropic hypogonadism which can mimic CDGP. So the gold standard is this follow-up. And we do, and one more thing, if we if the LH is stimulatable and if we know that we are dealing with CDGP, then we if the child is more than 14 years and if the child has psychological trauma, psychological impact of this delayed puberty in the child, we can kickstart the puberty in CDGP by giving 3 doses of low dose testosterone, 50 to 100 milligram monthly for 3 months we give to kick off puberty. And in CDGP, once we give this 3 doses and stop it, then the puberty will normally kickstart and progress in CDGP. Whereas in CHH, it will not progress.
Okay, okay.
The journal will be dealing with these points. So we can keep this in mind. So why serum inhibin B? The serum inhibin B varies across the ages and pubertal status. So deriving a normal range of inhibin B is a cumbersome task. And there are various studies describing various cutoffs ranging from right from 35 to 111 picograms per ml to differentiate between CDGP and IHH with varying sensitivity and specificity. So we don't have a good cutoff. It is always a confusion which cutoff to take in case of inhibin B. So this journal, Madam Sir?
Yeah, no, it's okay, madam. Please continue.
Okay, sir. So this journal we are discussing today is a systematic review and meta-analysis who have collected they have studied all the studies published so far, which have evaluated the diagnostic accuracy of serum inhibin B for differentiating these two conditions. This CDGP, which is a normal variant, and congenital hypogonadotropic hypogonadism. So I'm moving on to the study purpose without wasting your time. So I invite.
Yeah. Thank you for that excellent presentation, madam. Yeah, just thank you for an excellent, crystal clear presentation, madam. And we would like to, as madam was telling, request Dr. First presentation, madam. Analysis. Yeah. I will request Dr. Jeswin to JR consultant, JR Cosmopolitan Hospital Pediatrics to present the article. Over to Dr. Jeswin.
Am I audible?
Yes, ma'am.
Okay. Good evening. I'm Dr. Jeswin Mary James. I will be presenting the Journal Club today.
The slide is visible. No issues, madam. Please continue.
So the title of the study is Serum Inhibin B for differentiating between congenital hypogonadotropic hypogonadism and constitutional delay of growth and puberty, a systematic review and meta-analysis. This was published in the journal Endocrine Journal in January 2021. The authors being Yuting et al. And the study setting was Department of Endocrinology, Hospital of Sun Yat-sen University, China. The aim of the study is to perform a systematic review and meta-analysis to determine the diagnostic performance of serum inhibin B levels for differentiating the congenital hypogonadotropic hypogonadism and constitutional delay in growth and puberty. Coming to the methodology, this is a systematic review and meta-analysis. The study design of the included studies are diagnostic accuracy evaluation studies. That is, it is a study designed to assess the diagnostic performance of a test to assess, to differentiate a disease. Systematic review was done as per the PRISMA guidelines, preferred reporting items for systematic review and meta-analysis, which is a standard guideline for assessing any meta-analysis that will be dealt in detail later. PubMed, Embase, and Cochrane library databases were searched from date of inception to November 10, 2019 for studies examining the use of serum inhibin B to discriminate congenital hypogonadotropic hypogonadism and constitutional delay in growth and puberty. So the inclusion criteria of the studies including this meta-analysis were studies published in English, studies using serum inhibin B for differentiating CDGP and congenital hypogonadotropic hypogonadism, studies which reported overall sample size, sensitivity, and specificity values, which could be used for statistical analysis. The exclusion criteria were animal and in vitro studies were excluded from this meta-analysis, reviews, other meta-analysis and case reports, studies that reported unrelated statistical and clinical data, duplicate articles were not included, studies not related to objective of the study, and also the studies which included patients with functional hypothalamo-pituitary gonadal axis impairment were also included in this meta-analysis. So this is a flow diagram that showed the database search. So after searching the database, 648 records were obtained and the duplicates were removed. All the inclusion and exclusion criteria were applied. And finally, 7 studies were included in this meta-analysis. The data extracted from the studies include this meta-analysis were name of the first author, publication year, country of publication, journal name, study design, age of the participants, whether testosterone priming treatment was performed, testicular volume, INHB measurement method, congenital hypogonadotropic hypogonadism and constitutional delay in growth and puberty diagnostic standards, the cutoff values, the number of hypogonadotropic hypogonadism patients and delayed puberty patients, true positive, false positive, true negative, and false negative. The screening and data extractions were performed independently by 2 authors, and the disagreements between the 2 were resolved by a discussion with a 3rd researcher. So the quality of the studies included in this meta-analysis were done by a tool, QADAS tool, Quality Assessment of Diagnostic Accuracy Studies tool. The components of this tool being, first one is patient selection, that is the children with delayed puberty, index testing, that is serum inhibin B is indexes that is used, the reference standard, that is spontaneous complete pubertal development and testicular volume, and flow and timing. This is a diagram that shows this QADAS tool. These are the studies that are included in the meta-analysis, that is the 7 studies. And these are the components of the QADAS tool. And each and every components were assessed for the risk of bias. And the first 3 components, namely the patient selection, index tests, and reference standards were assessed for applicability concerns. And the results were interpreted as low, unclear, and high. For example, in the first study, for all the components of the tool is having a low risk of bias that is depicted in the green circles, and the first 3 components were having low applicability concerns. That means this is a good study that is included in this meta-analysis. So coming to the publication bias, since congenital hypogonadotropic hypogonadism is a rare disease, the number of studies in each method group was less than 10. And therefore, it was difficult to draw funnel plots to examine publication bias. Funnel plots, they are used to determine publication bias in any meta-analysis. And this is a visual aid that helps us to differentiate if there is any bias or heterogeneity in a meta-analysis. The results. The diagnostic accuracy of inhibin B to differentiate constitutional delay in growth and puberty and congenital hypogonadotropic hypogonadism. It was given a cutoff range of 56 to 113 picogram per ml. And from this study, we obtained a pooled sensitivity of 0.92 with a 95% confidence interval of 86 to 96% and a pooled specificity of 0.92 with 95% confidence interval of 88 to 94%. The discussion. From this included 7 studies, 7 cutoff values of INHB levels in boys with delayed puberty were identified. And it was in a range of 28.5 to 111 picogram per ml. This were using different assays. Generation 1 and generation 2 assays were included. So all these were, this were standardized to second generation ELISA, and a cutoff of 56 to 113 picogram per ml was obtained. The reason for variability in cutoff in these different studies are different inhibin B measurement methods, instruments, and lab techniques, different baseline testicular volume assessment methods like Prader's operometer, ultrasound measurement, whether the patients that is included in the studies were prior primed with testosterone or not. And finally, the congenital hypogonadotropic hypogonadism is a heterogeneous disorder with partial and complete forms, which also made the diagnosis complicated. From subgroup analysis, the following factors were identified as a source of variability in inhibin B cutoffs. These were severe puberty deficiency, that is with a testicular, those with a testicular volume less than or equal to 3 ml was having a higher diagnostic accuracy with inhibin B. And if the patients were previously primed with testosterone, we were giving higher cutoff value for INHB, and also gender, that is whether only boys were included in the studies or boys and girls were included in the studies also, were source of variability in INHB cutoff. So the conclusion is inhibin B level is useful for differentiation between congenital hypogonadotropic hypogonadism and constitutional delay in growth and puberty, especially in boys with delayed puberty and a testicular volume less than or equal to 3 ml. An inhibin B diagnostic range of 56 to 113 picogram per ml for boys and 20 picogram per ml for girls was used to distinguish between congenital hypogonadotropic hypogonadism and constitutional delay in growth and puberty. A combination of multiple parameters such as clinical characteristics, laboratory data, and genetic sequencing may ultimately provide high diagnostic accuracy and determination of prognosis. Thank you.
Thank you for that crystal clear presentation, especially explaining the terms and also making it simple and direct. Now, I would like to request Dr. Anju to present the analysis of the article. Or Dr. Anju.
Good evening, everybody. I am Dr. Anju. I'll be presenting the analysis of the journal. So this is the title of our journal, and part 1 will be the statistical analysis proper of the study. So this is the subset analysis of the journal and the each studies in it. We can see that the first study, that is the cotton study, was classified into 3 subsets based on the testicular volume. Based on the testicular volume, it was again divided into 3 subsets, and the Sukumar study was divided into 2 subsets based on the whether the participants received priming treatment of sex hormones. So a total of 10 studies, they have calculated it as 10 studies was analyzed. Again, another characteristic to note is standardized cutoff value. We can see that in different studies, different measurement methods were used to calculate the inhibin B value, and the cutoff value had to be standardized to generation 2 ELISA. We can see that DSL ELISA was used for 2 studies and OBI ELISA was used for 2 studies. These both are the generation 1 ELISA, and this assay method standardized to generation 2 ELISA using this formula. And the final standardized cutoff value was derived, which was ranging from 56 to 113 in boys and 24 girls. And we can see that true positives, false positive, false negative, true negative, all these values were derived to calculate the specificity and sensitivity. Another characteristic to note from the studies is the gender. 5 studies had only boys as participants, 1 study had only girls, and 1 study had both boys and girls. Another difference is the gold standard used to compare the inhibin B value. 6 studies had spontaneous and complete pubertal development at 18 years. These were the prospective studies, and 1 study had testicular volume used as gold standard. Coming to the statistical analysis proper of the study. So we can see that inhibin B, which was the test, was compared against the gold standard, which was either testicular volume or puberty at 18 years. And they have taken the total of true positives, false positive, false negative, true negative to derive pooled sensitivity, pooled specificity, pooled diagnostic odds ratio, and an SROC curve. Coming to exploration of heterogeneity. An inconsistency index, I-square, was used to evaluate heterogeneity. That means difference between studies. This is similar to skewed and or non-skewed studies. And when there was significant heterogeneity, that is I-square more than 50, a random effects model of analysis was used, which was chi-square. And if there was low or moderate heterogeneity, I-square less than 50%, fixed effects model of analysis was used, which was Cochrane Q. This is similar to parametric and non-parametric tests. We'll go to the forest plot for each entity. This is the forest plot for specificity. We can see that the red dots, there are a total of 10 red dots, which is showing the individual specificity of all 10 studies. And this is ranging from 75% to 100%. For these 4 studies, it was 100%. And this blue line represents the confidence interval of that individual specificity. The red diamond shows the pooled specificity, which was 92%, and the area between the red lines give the confidence interval of the pooled specificity, which was 88% to 94%. Similarly, for the pooled sensitivity, we can see it ranges from 80% to 100% again, with the pooled sensitivity of 92%, with confidence interval ranging from 86 to 96%. So both pool sensitivity and specificity was 92%, which shows that the test had a very high diagnostic accuracy in the given cutoff range. Coming to the pooled diagnostic odds ratio, which was 104, which means that there was 104 times chance that the child had congenital to differentiate between both conditions. Next is the pooled negative likelihood ratio, which was only 10%, and the pooled positive likelihood ratio was 933%. Coming to the SROC curve. SROC curve was a curve which had sensitivity in the y-axis and 1 minus specificity in the x-axis. And we can see that for an ideal study, the area under the curve should be 1. And for our study, the area under the curve was 0.96. Which shows that our test had a very good performance along the cutoff values. This is the subgroup analysis where they have looked for the heterogeneity, that is the I-square. 2 points to note from this table. One is when the testicular volume was less than or equal to 3 ml, the study had very good sensitivity, which means the p-value was less than 0.05. And another was when there was only boys only study, the specificity had very good accuracy. So the results of the subgroup analysis suggested that the heterogeneity mainly stemmed from the testicular volume value, different sampling condition, and assessment with or without testosterone treatment. So these were the confounders found from the study. Strength of the study. This was the first meta-analysis for diagnostic efficacy of inhibin B to distinguish between CHH and CDGP. CHH being a very rare disease. Limitation was our study, even though it was a meta-analysis with subset study, there was only 10 studies which were included. This did not determine significant cutoff value. It had from the study, we got only a cutoff range for inhibin B, and there was publication bias due to less number of studies, and studies in English language were only taken. So moving on to part 2 of my discussion, which is the PRISMA.
Madam, kindly keep it precise and as short as possible so that we can keep up the time. Thank you so much.
Prisma is the preferred reporting system for systematic reviews and meta-analysis, and it consists of 27-item checklist with a separate checklist for abstract. So I've marked green for all the points which our study was satisfying, orange if it was partially satisfying, and red if it was not satisfying. Going through Prisma, we can see the abstract in detail later. Here in the methods, information sources, they did not specify the date in which each source was last searched or consulted. So it has gotten only a partial mark. And looking through the checklist, we can see all other characters, all other checklist was satisfied by our study. Coming to the checklist for abstract, the title was not given. The risk of bias and synthesis of result was not discussed in abstract. Limitation of evidence was not discussed in abstract. Funding and registration was not given in abstract. So abstract was marked as partially completed. Even with this, we can see that our study was satisfying abstract checklist 6 out of 12 and Prisma, complete Prisma checklist 27 out of 28, which showed that our quality of this meta-analysis was excellent. Thank you.
You want to elaborate on the Prisma score, madam? Actually, you can take 1 or 2 minutes for, I mean, if you want to explain the components of the Prisma, if you want.
We can go through each point one by one. Title, whether the study had reported, identified the report as a systematic review. This was there in the title. Abstract, I'll be looking through the abstract checklist later. Rationale and objectives was provided in the introduction. They have included the inclusion and exclusion criteria, specified all databases, but not specified the date when which each source was last searched or consulted. So this had this was partially satisfied by our study. Then the search strategy, selection process, data collection process, data items, study risk of bias assessment was all done by within our study.
Okay.
Then effect measures, synthesis methods, reporting of bias assessment. This was not done because there was no missing results in our study. They had called up the authors and completed every data. Then certainty assessment, confidence interval was given for that. In study selection, study characteristics, risk of bias, all this was done by the quadas too. Results of individual study, results of synthesis, reporting biases, this was all presented through forest plot. Certainty of evidence with the confidence interval was in the study. Discussion, they had given a general interpretation and discussed limitation of evidence as well as limitation of review process. And they have discussed the implication for practice policy and future research. And within other information, they have provided registration and protocol and financial or non-financial support, and whether there was no competing interest of review authors, and they have shared this data as open access. So all this was satisfied by our study.
Okay. Yeah, abstract we have discussed. That we have discussed, right? So thank you so much for that elaborate and excellent discussion. And I would like to request Dr. Ramankutty sir to offer his sir's comments.
I think it's a very interesting paper, and I think both the mentor who described the situation, the context, which was very good because we, especially me, who is not a clinician, could understand the situation very well, and the JRs who presented were also very good, excellent presentation, and congratulations for all of you. Only thing I found a little, maybe because of course they are not exposed to these things, the LR, the likelihood ratio, is not a percentage. Likelihood ratio is a number. Now, likelihood ratio is a number. Suppose you have a pre-test assessment of the situation. That's called the pre-test odds. You multiply that by the likelihood ratio to get the post-test odds. And odds is a form of probability. You can convert back into probability from odds, and I don't want to go into all that to confuse you. Anyway, that is a general principle. So it's a number, it's not a percentage. That's what I wanted to say. That's the only thing I think where you went wrong. Generally, I think the study is excellent and it's been written up well and presented well. So no questions about that. And nowadays, of course, as you rightly pointed out, you have the guidelines, the Prisma, and the quadas, and also just have a checklist. You just can go through the thing and see whether it's a good study or not. So that's a great advantage. Only thing I want to say is about meta-analysis and systematic reviews, because more and more these are coming up. Nowadays, systematic review is accepted as a research design, just like a cohort study or case control study. So systematic review is not easy to do. It cannot be done by one person, as it has been pointed out. It needs a team. So you need two people to review the studies, and then you have to have a third person to look at any disagreements between the two independent reviewers. Then you may have a methodology expert or a statistician to look at the statistics. So it's a team effort, and I think it's a very good exercise if you can be involved in a systematic review. But the only thing I want to tell you is that a meta-analysis always follows a systematic review. There is no meta-analysis without a systematic review. But sometimes you stop at a systematic review because you don't have enough numbers. You may not be able to do the meta-analysis. Suppose you finally end up with only 2 or 3 studies, then you just cannot do a proper meta-analysis. Meta-analysis, of course, means put the numbers, pool the numbers, and then find out the final answer, just like you have said. And in this case, usually in a meta-analysis, you're looking at an odds ratio or a risk ratio, something like that, which will have, each study will have report a risk ratio or an odds ratio, and then you pull it together and find out what is a combined risk ratio. But here you have 4 separate measures, like the sensitivity, the specificity, the positive predictive value, negative predictive value. So all of these have been compared, and so that's why it's a very good, excellent study. Then you have the guidelines for the diagnostic studies, as you said. And this is what is actually what nowadays in the jargon of artificial intelligence, they call it the classification problem. So you want to classify the patient into one group or the other. Will it respond to treatment or not? Like that. So that's what I call it. So next step is to build a AI model. Of course, you can do that, but if you have number of, lot of data points, but that is not our, what has been reported is, of course, from, I think, 7 studies, I don't know. Anyway, so it's so you go through a process of filtering all the studies and picking out the best ones, and then you combine the results from all those. So that is how it is. And the other thing I want to tell you is ROC. Of course, ROC is a receiver operating characteristics. That is the full form of ROC. And interestingly, this is just a side comment, which you might wonder why it is called ROC. That is because it was invented by people who, suppose, when you invented radar, so you are looking at some flying object, which might be an enemy plane or not. So you have a signal, your radio receiver, that's called the receiver, and the receiver operating characteristics, whether it correctly identifies the plane as an enemy aircraft or not. So that is how it first started. So that is why it's called ROC curve. So you might wonder why it is called an ROC curve in medicine also. It came from military jargon. So that is, just aside as just a piece of information for you. So the ROC curve, as rightly pointed out, has to be as near 1 as possible, which means the curve has to go very near the upper left corner. So, but no diagnostic test or no thing is very perfect. So there is always a gap, and that is why you can't have a test with 1 as a ROC. It's very, very difficult. It is very, and I would be very suspicious if it reported such a high ROC. So this is very good, like 0.92 is excellent. So which means that it can actually recognize these 2 conditions, discriminate between these 2 conditions. So that is the essence of this story, is that this test is very good. And that's all I want to say. If you have any doubts, of course, I can.
Thank you, Ramankutty sir, for that enlightening presentation. And I would like to request to ask Dr. Soumya Madam to comment after Ramankutty sir has told. If there's anything to add, or if anybody has something to discuss, anything to ask, they're free to communicate. So I would like to request everybody. First over to Dr. Soumya Madam.
Thank you, sir, for that extensive and that interesting. You described everything in a very interesting way. That shows how how much obsession you have for statistics, how much you love statistics. Thank you so
I
much.
should have been a statistician. I always think.
Sir. And I would like to conclude this presentation by giving a clinical point relevant to our all practicing doctors, is that how can we extrapolate this data which they have given us into a clinical practice. So they didn't stop, they couldn't derive one single cutoff just above which this is CDGP, below which CHH. So they have given us a range, because a single cutoff with good sensitivity and specificity could not be identified from this data. It means that when you go higher up in the cutoff, that is when the cutoff is between 56 and 113. So if you use a cutoff of 113, you have good specificity, but the sensitivity is low. But if you use a lower cutoff, that is 56, then your sensitivity is good, but specificity is less. So we as clinicians are put with to match our clinical judgment with while using this cutoff in our clinical practice. So if we have a high suspicion of the disease, that is pre-test probability of a disease is high. So the test positive means it is CDGP. Because its higher value means it is CDGP. So if you clinically suspect CDGP well, if you want this test to perform well, then you take a higher cutoff, because we want specificity in that at that point. And if your clinical suspicion is low, then you want to test with good sensitivity. So a lower cutoff may be chosen when you have a low suspicion. That is the take-home message which the meta-analysis is trying to give us regarding this cutoff value of inhibin B in differentiating these two conditions. I hope I'm right, sir. Ramankutty sir, correct me.
Yeah, I think that's an excellent point, because many clinicians I have seen, and some people are surprised when I point out this, that there is always a trade-off between sensitivity and specificity. You cannot have perfect sensitivity and specificity. If you increase the sensitivity, you will lose on the specificity. And if you increase the specificity, you lose on the sensitivity. So you have to decide what is it that you desire. So is the cost of missing a case more important or more, is it more costlier than, not picking up a case like that? So you have to decide, depending on the situation, which is a more expensive mistake to make. So, and you have to avoid that. So that is, I think that is rightly pointed out by Dr. Soumya. And the second point is always that predictive value is always, it's not just dependent on the sensitivity and specificity, it's always dependent on the underlying condition. So if it's a rare condition, even with the high sensitivity and specificity, you do end up making a lot of false positives. So that is something you have to bear in mind.
Thank you, sir. That is very important, actually. Dr. Soumya, madam, we were discussing during the during the trial and all, I was also asking very naive questions, and I think it has turned out good, because most of the terms were explained during the session, and all. That is very interesting and all. But madam was telling that madam is also already using the serum inhibin values. So could you add a word on the clinical experience of madam's regarding this?
We routinely do inhibin B to differentiate these two conditions, but the cutoff we take with a pinch of salt only because of this fact.
Yes.
So we always
That's what I'm going to
give more weightage to our clinical judgment and the other tests also. So this is a surrogative test for helping us sorting out this condition. So if I have a child whose inhibin B is well above 111, so then I'm more safe that in diagnosing a CDGP. Or if the value is less than 56, and I'm more safe in to make a diagnosis of CHH and start the treatment right away itself. So that is the, we are using it like that in the clinical practice. I hope all practicing endocrinologists are doing that in such a manner.
Thank you, madam.
And this inhibin, they are using it another context also to follow up a case of the CHH. When CHH in congenital hypogonadotropic hypogonadism, this will be low. So once we start treatment with gonadotropins to induce puberty, we use this inhibin B to follow up to see whether the testis is responding or not. An increase in inhibin B may be a better marker for that too. So in that way also, we are clinically using inhibin B. All these which we have discussed is majorly applies to boys, because in girls CDGP is erratum. So whatever we have discussed so far majorly applies to boys with delayed puberty.
And thank you, Soumya madam, for coming up with this excellent paper, which actually, and sir was also enjoying analyzing this paper. I was seeing that actually, because I was seeing sir for many journal clubs and all, and we also enjoyed sir's comments and all. And we have another endocrinologist with us from the KIMS Hospital, my senior and my friend, Dr. Sheija Madhavan. Madam, could you offer your thoughts, madam, at this juncture, madam, regarding this session and the article? Clinical experience.
Very nicely presented, Dr. Soumya and the junior doctors. About the case, delayed puberty is not a very uncommon condition. We do come across children, and as Dr. Soumya has mentioned, it is very difficult to differentiate between constitutional delay in growth and puberty and congenital hypogonadotropic hypogonadism. And the margin between the two is so blurred because what we call a CDGP could be a case of partial CHH and even the other way around. So it is always good to have a good diagnostic test with which we can differentiate. But what I would like to ask Dr. Soumya is how this test is going to alter clinical practice. Because when we have a child with delayed puberty, especially in an adolescent 14, 15-year-old boy, it causes so much psychological distress. And we usually end up starting treatment. And whatever be the clinical diagnosis, we start treatment, we stop, and then we reassess. So if the puberty progresses, we term that as CDGP. And if we need to continue the hormone treatment, that is CHH. So will inhibin be throw light on that, whether we can, we need to continue. But is it not a clinical, we give a therapeutic trial and then assess, is it not that way?
Yes, ma'am. Very rightly pointed out, ma'am. Because no, as ma'am have told, this delayed puberty causes a significant psychological impact on the child as well as a negative impact on the bone too, because of delayed exposure to sex steroids. And earlier the practice was to give this testosterone priming itself was used as a test to differentiate between these two. If it kickstarts, then it is CDGP. If it is not, but now if it is CHH, the treatment is probably gonadotropins. Like we give FSH and LH to kickstart. So pubertal induction may be better done with. There are two options for inducing puberty in children with congenital hypogonadotropic hypogonadism. Either you can give sex steroids, that is testosterone treatment itself, or you can give gonadotropins, FSH plus LH. There are earlier it was said that you start with testosterone, and at the age of when the fertility is required, then you go for gonadotropins, like when the child is planning for a marriage or at that age. But now there are various studies coming up which says that those children who had testosterone, who had received testosterone prior to gonadotropin therapy, they respond less to gonadotropin therapy later. So previous treatment with testosterone was considered to be a risk factor for lesser response to gonadotropin therapy later. So nowadays it is considered better way to start gonadotropin therapy for pubertal induction from at the outset itself for CHH for a better fertility outcome later. So you increase the testicular volume and get the fertility part, increase testicular volume first, then once we have done that, then you can go for continuation with testosterone. So in that context, diagnosing this two and differentiating this two at the outset itself is important for pubertal induction, the treatment. So in that way, whatever tests which we have, if that could differentiate this at the outset will help us to decide the treatment. We may not give this testosterone priming initially if it is a CHH, because no, that may decrease the outcome of gonadotropin therapy. So in that way, it can help us. But as ma'am have told that the margin is very much blurred, and the only test, only gold standard diagnose differentiation, this is a follow-up. Even sometimes CHH can turn out to be a partial, can have a spontaneous reversal, and CDGP sometimes may be a partial CHH which is going for. So it is the gold standard is always follow-up, but this will help us to differentiate this and planning the management.
Thank you.
Thank you for showing us without a very beautiful question, ma'am, actually.
I think
Thank
I
you,
saw
Sheija madam, for
somewhere in
joining
that
us.
paper, some paper I remember, there is a part where they say timing with testosterone and then the sensitivity and specificity go up to 100%. Interesting. I also thought it's very interesting. I don't know what it means, but
Yes, sir. When we give a priming, then in CDGP, the inhibin B levels will be higher cutoff can be used for when after priming. So that will increase the diagnostic accuracy. Sir.
I was also wondering whether that can affect the test result, the priming testosterone.
I think it's discussed in the paper. I remember seeing that, but I don't know where.
Yes, sir. The study, the meta-analysis they have derived a separate cutoff for when priming is used or not. There are cutoff of 96.7 for when priming was given. So inhibin B can get stimulated with this, priming. The cutoff can be higher. Probably because of that.
Thank you.
Yeah. Thank you for that excellent discussion. Actually, this is one of the most fruitful sessions. Thank you, Shrija Madam, for joining and for contributing, Madam. And I think it is already 8:40. And Ramankutty sir, shall we wind up, sir, if there are no other? Yeah, thank you. I would come to a formal thanking session. Ramankutty sir, I apologize for any inappropriate comments if I have made, and also, and thanks for being with us from the beginning until this late hours actually, and for the expert comments and all. So I would like to thank Dr. Joso sir, Dr. Rugmini Madam, John Sebastian sir, Krishnamohan sir, and all the officials, IAP officials who have joined actually, and also Dr. Ramankutty sir for joining us, and thank you from all of us, and have a great time, sir. And I would also like to thank Dr. Soumya Madam, who has excellently done. I mean, it was a very useful and throwing a lot of light to this, because we know that these areas are a bit. So especially for the paper and all, and for the initial, background, and for the excellent discussion, and for mentoring our great PGs. And I would like to also thank the two PGs, JS, who have excellently presented and taken great effort, and have crystal clearly presented, and making it very simple and aesthetically very pleasant slide. And thanks Jesna for that crisp presentation, and thanks Anju for the statistical analysis as well as the Prisma analysis, and you have done a great job. Thanks from myself and from IAP, and once again thanks for all who have joined the session. And I think we can call today, and a great time ahead. Good night all. Thank you, Ramankutty sir. Thank you, Soumya Madam. Thank you, Anju.